I think Miami Breast is arguably the single most important educational event for medical teams faced with patients with breast cancer. After 34 years, Miami has educated more physicians, more nurses, more navigators, maybe than all of the other meetings combined. Miami has never been more important. And really this year, maybe more than ever in the past, this is about the patient. Breast is a complicated family of diseases. Miami allows the clinician to hear all different perspectives: medical oncology, surgery, radiation, genetics, to go home and offer the best chance for their patients to have a cure. I think there are a number of themes for Miami 2019. None is more important than the role of immuno-oncology. There's exciting data that we'll be reviewing from the European School of Medical Oncology looking at the role of immunotherapy in triple-negative breast cancer. So we're very excited about this, and we'll do a very deep dive on that. Looked at from 50,000 feet, a lot of what happens is about class prediction. How do we treat the specific breast cancer in the patient in front of us in the most effective way with the least comorbidities? That's a huge focus this year at Miami. We know that even triple-negative breast cancer is a family of diseases. It's not a single disease. How do we separate the family members out? So we'll be talking about genomics, and we'll be talking about novel biomarkers, and we'll be talking about, believe it or not, genetic testing for germline mutations and how those impact our treatment decisions. So a lot of important stuff to talk about this year. If we go back to ASCO, we now know that with the 21 gene assay in ER-positive, HER2-negative, node-negative breast cancer, which is a very common subset, maybe 60% or 65% of breast cancer, that we can spare more and more women cytotoxic chemotherapy by showing that they are in the low recurrence score group. That was the really big news coming out of ASCO. Looking at ESMO this week, we know that in PD-L1, PD-1 positive triple-negative breast cancer, there's an option that appears to be effective in the immuno-oncology space. We've been looking at data on CDK4/6 inhibitors coupled with estrogen receptor downregulators, again in the metastatic setting, showing really great effect. Great. And so there's also this perennial question about how long is long enough to block HER2? How long should trastuzumab be given? And of course, in the United States, the standard is 12 months. But there's increasing data that maybe, possibly 6 months might be as effective. And a few papers at ESMO looked at that question as well. So really a lot of exciting stuff coming out of Europe. I suspect that several speakers will be looking at Persephone from different perspectives. While the trial showed really no substantial difference between 6 and 12 months, there are differences in the outcome. It looks, for example, like the cardiotoxicity rate in the European patients are about twice the cardiotoxicity rate in US patients. We need to do a deep dive on that. Having said that, there are 5 or 6 different studies now which really suggest that 6 months might eventually be the right answer. However, until we have a meta-analysis looking at individual patient subsets, our standard is still 12 months in this country. Both the low-risk group that was reported from TAILORx and the randomized intermediate group from TAILORx have led us in the same direction. And I would summarize it by saying de-escalation. In the 1990s, every woman with a 1 centimeter or greater breast cancer got chemo. Node negative, node positive, high grade, low grade, which meant the vast majority of women got chemo. And there was trial data suggesting a survival benefit in a small but real group of patients. And in those days, we were probably treating 100 women to help 6, or 100 women to help 8. So what TAILORx has brought us to is Let's identify those patients who will actually get the most benefit from chemo while sparing the low-risk patients. So with the 2 TAILOR-X studies now, we can show that 60 or 70% of women who would have gotten chemotherapy in the 1990s will not benefit from it today. So this is really, it's extremely important. It's extremely good news for our patients with ER-positive, HER2-negative breast cancer. My passion for the past few years has been the opioid crisis in the United States and frankly worldwide. In 2017, 72,000 Americans lost their life to opioid addiction. We know that 4 out of 5 heroin users started with MD-prescribed opioids. We've got to change this. And in the oncology world, and in particular in the breast cancer world, remember, there are 250,000 women having breast cancer surgery every year, but there are another 700,000 having procedures for what turns out to be benign disease or reconstructive surgery. So an enormous number, 1 million American women and some men are having surgery. We've got to find ways to achieve our goals of treating breast cancer without opioids. So I'm going to be giving one of the plenary session talks on what we've done at Maimonides Medical Center in Brooklyn, where we have a deep experience with opioid-free surgery. And I'll be presenting our experience, and I'll be sharing our strategy with the audience. There are other topics that we want to address that are very personal, like physician burnout, which is very real. Breast cancer is a very high volume, long hours. Sometimes my colleagues refer to it as the bad news business because we spend so much time sharing biopsy reports that show cancer or tests that show metastasis or treatments that might not be quite as effective as we'd like. That takes a toll on the physician that's giving the bad news, and often in high numbers. And so we will have several speakers dealing with strategies to confront and address physician burnout. Someone might say, what's the biggest advance in breast cancer in the last 10 years? And there would be a lot of really great contenders. HER2 testing, HER2 targeting has been big. Better ways to block estrogen, better imaging, 3D mammography. You would probably get 20 different answers. But I would argue that none of them has been more important than genomics. We treated breast cancer for the first 3/4 of my career based on descriptive morphology. The tumor was 2 centimeters. I looked down a microscope. It looked poorly differentiated. Let's treat it. And time again, that was inadequate. A patient either did really well or not so well. We can't look down a microscope at a breast cancer and determine its unique characteristics. That's what genomics allows us to do. And so I think we will be really highlighting genomics both in the invasive and in the in situ cancer setting at Miami this year. These have really been game changers for us and for our patients, and we're excited to talk about them. To anyone out there watching who hasn't been to Miami, I would say give it a try. It's a unique experience. It's a chance to learn what your colleagues are thinking, to interact with our world-class faculty. Miami Beach in March is not so bad either. This year we've actually shortened the program a little bit for more pool time or more beach time, more family time. So bring your family, come down to Miami, and I hope to see you there.